Rafael, hi.
Hi.
It's finally nice to meet you here. We're friends on Twitter, but it's
exactly
nice to see you.
Virtual thing. Yeah. We hope we could do something for the next year. I hope.
Rafael always gave us delicious dishes in the Facebook.
Yes, we have today some delicious dishes, of course. We have to get ready for the session.
Yeah. Okay. We have the last session in our cardio box today. And, I would like to thank Dr. Julia Graspa and Dr. Rafael Vidal Perez and Dr. Giuseppe Vergari for being with us in so late and where they are now. As I just said in the break, in Egypt, we're all awake, but I appreciate that they are staying to be with us. And of course, also Professor Ahmed Shawqi, who will be presenting with us today. We used to think that valvular heart disease was an Egyptian condition because of rheumatic heart disease, and that people in the West did not get a lot of it, at least not in young patients. However, this is changing, and there's a huge interest again in valvular heart disease because of all the percutaneous interventions. And our first presentation today by Professor Rafael Vidal Perez from Spain, Spain, the land of Real Madrid and Barcelona, you like one and you hate the other, probably. We love both in Egypt. Is going to give us an amazing presentation on heart failure due to valvular heart disease. This is a very tricky subject, and we already saw an amazing case earlier, which was treated by Tavi, and now we're really looking forward for this presentation. Dr. Perez and I are friends on Twitter, and he's a fantastic tweet, and I'm so happy to see him albeit on video, but still it's wonderful. Thank you. Thank you very much.
First of all, I want to thank the kind invitation by you, and also for the JACC case report, Julia Grapsa, the editor-in-chief. And I'm happy to show my cases and to see that the other case was similar but not the same, because I was thinking, okay, they are going to have something similar, but it's not the same. I think, as you say in the one-stop wall, I think the thing is, on valvular disease, I think we have to start to think also in the diseases after changing your native valve. That is things that I'm going to show you in a brief. So this is the first one that I'm going to show you, and we'll try to explain something about the guidelines on some topics. And I will show you some cases from JACC case reports. I think it's also important to show that the things that we find in the clinical practice are the same. So this is a real case, not published in JACC case reports also, but it is a 70-year-old man, hypertension, dyslipidemia. It had at the start the cardiac rheumatic disease that we spoke. He has mitral stenosis and regurgitation. He was treated in 2005 with mechanic prosthesis and tricuspid ring. And in 2009, he has an admission with endocarditis. And the management was medical in that case. He has also atrial fibrillation. And now we have that this patient is in follow-up because other diseases came, like the other case, with severe aortic stenosis and moderate aortic regurgitation. It was in good functional class, and it came to the hospital because of shortness of breath. It was this with 150 of blood pressure, and he was tachycardic, arrhythmic, asystolic murmuring apex, and these signs of heart failure in the X-ray. And we checked in the lab thing that is important in this kind of patients with prosthesis and atrial fibrillation. The NR was low in the last weeks. And this is the first echo. As you can see here, you can see that the left ventricular ejection fraction is more or less near to mild depressed. And we can say here, see here also the aortic stenosis. Of course, it was significant. But if we observe something here, we can start to think that the two leaflets are not working quite well. I think it's very clear here in the four-chamber view. And we have a high gradient here of a maximum of 24 and medium of 7. In other approaches, we can get a medium grading of 10. So we decided to see the valve better. That's the point. And here you can see that it's not always the time the leaflet moving the same path as we see it in the transthoracic. I think it's due to the anticoagulation, but you can see something there that probably could be pannus, it could be a thrombus. And the nice thing, and I think it's very useful in this kind of patients, is to check with fluoroscopy what is going on with the leaflets. And you can see one of the leaflets is not moving quite well. I think it's quite important. And this mass, it was like 6.2 millimeters, and we made also a 3D. And you can see here also the valve, but it's not really clear what's going on in 3D for this approach. But the main thing is that we have a mass there. So we treat the patient in the heart failure with diuretics, digoxin, and beta blockers. We corrected the anticoagulation, and we with the unfractionated heparin, and we add aspirin. It could be something to discuss. Of course, as I showed you, we have this partial block with a thrombus, but we don't know if behind it's a pannus or it's a thrombus. That's one of the points. As it was not so unstable, we decided not to do fibrinolysis. Then we have this discussion with the heart team that it has very many things to discuss. That's severe aortic stenosis, mitral mechanical valve infarction, so double valve surgery, maybe femoral TAVR, or adjusting well the anticoagulation, or maybe going through a surgical thing of sutureless aortic valve replacement and review the mitral valve. Well, we make studies previously. You see that we don't have coronary arteries disease. We have good femoral access. You can see here that we have not absent of a coronary stenosis, and I don't change the case. You can see that now what happens here, you can see how the leaflets are working well, and it's because we get a better anticoagulation. So probably the thrombus was there. So the decision of the heart team in this case was to go through this femoral TAVR and anticoagulation for this mitral valve. But this happened that the things get solved, but we have a new thrombosis event with new heart failure, and at the end the management was to be surgical in our department. And we went for this sutureless valve, Perceval, and the result was good. And I will show you, this is the 1 month after surgery. You can see that the things are working better. You can see the 2 discs here working quite well. We have less degrees, and of course we don't have the aortic stenosis. So the point here is one of the discussions. I will leave it, I think, for the end, because I will show you now 2 more cases that are similar. Is that the guidelines what say you have to check always if it's an obstructive mechanical prosthetic thrombosis, then you have to go to something more aggressive, like, okay, probably surgery or fibrinolysis. You can wait for this kind of medical management if you have an obstruction, and you have to decide in relation of the risk of the patient. But when the patient is more stable and you see that it's not obstructive at all, you can think on the thrombus side and think what is going on with the anticoagulation. And then you can go slowly, as we made in our case. The point is that also if you have some thromboembolic event or other things, you can think that probably you need to help with the aspirin, but it's not clear if it helps you to a better anticoagulation in this case. And I think another topic that is important is the bioprosthetic valve failure that we could have with TAVR is there, but the risk of thrombosis is lower, as the guidelines say. And another point is more or less the management in the American guidelines is more or less similar what to perform, as we showed you in the case. But the point is here that I think is very interesting, this approach. I don't know if the new guidelines of the European Society will go through this, but I think it's important, this thing of help us to decide when to go to surgery or fibrinolysis, depending on what different things we see in the studies of imaging and how the patient is going on. So I think it's a good thing to remember that this table. Another point is how to decide if it's a pannus or not. It's something tricky. Of course, there are more risk of pannus in mitral valves. And this is another document that I think is very interesting on imaging recommendation of prosthetic heart valves that is made by many societies. And this figure I think is interesting because it shows you more or less some hints to know where is a pannus or a thrombus. And I think it's something that you have to keep in mind. But I want to share with you another 2 cases very fast before I finish these presentations. That is one is about another mechanical prosthesis, but you can have patients that have an acute coronary syndrome due to thrombus. This was the same case. Heart failure. We have a more stable patient in relation with blood pressure, but he needs oxygen, and he has previously a mechanical prosthesis, both aortic and mitral. And in the lab test, you find that the patient has some high gradient also in the aortic valve. And when we check with transesophageal echo, this is a case published in JACC if you want to check it more. The mechanical discs were no easy show, but we have the information that it was good anticoagulated when we get the lab test. But when we check it with CT scan, I think it's an essential technique in some cases, and this is well illustrated here. We have this thrombus that is making that this not moving. It's another way to see it with a different technique, but we have good resolution now with CT scans, and we can get this information. And in this case, it has also another complication that it was when deciding what to do with the patient has a coronary event with abnormalities in the LAD, and he needs fibrinolysis to solve his problem. And after all, they made a cath, and you will see here that he has a distal occlusion, and the management finally was with medical management, because it was not, how to say, with all the thing of the thrombus, starting new anticoagulation, they decided that it could be complex to add more things on the treatment. And one of the good things of this case is that they show you how to deal with this situation of what is the valve thrombosis. But the most important thing, I think, is this: when you have this embolism, that this is the strange part of the case, is what to do with you have an embolism due to this thrombus in the valve. That you have to check probably with IBUS and OCT what to do. If a plaque erosion, maybe you need to do a stenting, but this is something resolved with no plaque. Maybe the best solution, like in this case, is to keep anticoagulation. To finalize, I will want to show you another thing that is also TAVR could have thrombosis problems. That is the next step. If your patient has a high risk for thrombosis, that is this situation of polycythemia vera. This patient have another case of dyspnea and fatigue. The same problem, we have some kind of obstruction. In this case, he was with apixaban that it was not stopped previously due to a dental procedure, so we can say, oh, he could forgot to keep the medication, but he was keeping the medication. But in this case, the point was that also we have leukocytosis, and we could think, okay, maybe it's endocarditis. And when they make the transthoracic echo that we'll show you now, you can see these thickened valves that it was due to a thrombosis, and it was confirmed with the transesophageal echo. And at the end, they decided, because it was thrombosis, to change the valve and put a new mechanical one. I think one of the key points is also here that we can go through transesophageal echo instead of CT to check this situation. And I think it's important in this hypercoagulable stage, I did discuss in the take-home message, that you have to be very sure that what is the anticoagulation strategy. I think you were discussing before also what to do if the patient has a PCR or not. I think this is a great document published very, very recently. And I think it's how to manage these patients that have an indication of oral anticoagulation, if they need stents or not, what to do. I think it's something good to review. As also another thing that is this one, because this patient was with apixaban. This one, they decided to keep apixaban for a prosthesis. If you will read these new recommendations just published, they say that, okay, it's acceptable to go with a NOAC in this kind of patients. So to finalize, as Steve Jobs says, one more thing, remember also that when you do another kind of procedures, it's a great paper also to check on JACC case reports. It's also, if you put a mitral clip, you can have many problems also when you solve this. You can have an endocarditis, you can put the clip but not make the things well. Also, you can have thrombus after the transseptal puncture, or maybe leave a different disease like a mitral stenosis. And I think it's another great paper dealing with valve disease. So I invite you to read this paper too. And thanks for your kind attention, and ready to discuss whatever you want.
Thank you very much. This was an absolutely brilliant presentation. I think you tried to show us as well some guidelines, but in reality, all those patients are so outside
Yes.
guideline and trials. These are individual human beings with incredible problems that you managed to, and the treating physicians have managed to help, sometimes using innovative or unorthodox ways. And it's very, very important to remember that all the procedures that we do have complications. We always get shown the good side of cases, but it's extremely important to know that our fragile patients have a lot of them have complications that we don't see. So it's wonderful. Any question from the audience, or would you like to postpone? Are you staying with us to the end, or
Yes,
shall,
no problem. I'll be there.
Okay. A quick question from Professor Tariq Zawawi, and then we go to Dr. Vergaro's presentation. Then we can take questions for the entire session.
I have a short comment and one question. My comment about the two cases you presented and the case presented by Professor Karim, that the patients with valvular heart disease, we have to interfere early before left ventricular dysfunction. The patients may develop after valve replacement what is called afterload mismatch, and this may cause more deterioration and irreversible left ventricular dysfunction. My question about the patients with heart failure and severe mitral regurg. This severe mitral regurg may be secondary to heart failure, functional mitral regurg, and this functional mitral regurg may cause further deterioration of left ventricular function. For management of such cases, there is a transcatheter mitral valve repair. We have two trials address this point, the MITRA FR trial and the COOPT trial. Actually, the MITRA FR trial failed to show benefit for reduction of mortality and heart failure hospitalization. However, the COOPT trial was positive for reduction of mortality and heart failure hospitalization. What is the explanation for this?
I think, as you say at the beginning, one of the key points is the evolution of the case. I think maybe if you go too late, one of the things that was discussed in between the two trials is how the performance of that ventricles was. Probably in COOPT, they take the patients in a better momentum, I think. This could help to have better results. But in some analysis, some people say that this was not related with volumes or remodeling of the left ventricle. But I think probably in some of the cases, if you wait too much, you don't get the benefit. So I think, as you see also in my first case, the aortic stenosis probably was giving more problems. He was to be intervened because of the problem of the mitral, but he has depressed left ventricular ejection fraction as least mild, and probably it's also too late for aortic stenosis. So in valvular disease, I think waiting it's not the best decision.
Thank you.
Thank you.